diagnosis. They are usually developed by experts. We have an expert panel. Process. Okay, there's a process that goes through, and there's a lot of research and evidence-based information that gets reviewed before guidelines are developed. So basically, it's like don't walk in the park alone. Don't walk in the park alone. You shine touch for you, right? That's what guidelines do. Guidelines are open to make decisions, better decisions, evidence-based decisions for your patients' benefits. So guidelines are important, and it's important that we use them to inform our choices. So what do current guidelines say about different aspects of UTI management? When it comes to UTI management, like we said, we're dealing with management of UTIs. We need to reimagine it. So first thing in managing a disease or an infection is that you need to understand it. If you don't understand it, you can't move forward. If you can't identify it, you can't diagnose it, you can't move forward. Diagnosis is very important before we start talking about the right medication to use, right antibiotic to use, and all that. So what the current guidelines say about classification of UTIs, there's a new classification. What we used to have complicated and uncomplicated UTIs. But right now there's a new classification by the European Association of Neurology and their new 2025 guidelines on neurological infections. So the new classification is based on clinical presentation, risk factors, and severity of the infection. So we have UTIs classified into localized and systemic UTIs. Localized UTIs and systemic UTIs. So localized UTIs refers to cystitis, inflammation of the bladder, without any signs and symptoms of systemic infection in either sex, whether male or female. We're going to see symptoms of systemic infections in the next slide. So you have someone coming with the classical symptoms of cystitis, which is dysuria, pain and urination, urinary urgency, urinary frequency. These three symptoms are the telltale sign of cystitis, and no vaginal discharge, and this patient does not have fever or any other sign of systemic infection. It is referred to as a localized UTI. So systemic UTI is referred to UTI that have signs and symptoms of systemic infection, with or without localized symptoms. So the person can have localized symptoms, like the three telltale symptoms of cystitis that I mentioned, and the person also has systemic symptoms linked them. It's a systemic UTI. Okay, so this classification is important now because it helps to distinguish between mild, moderate, and severe infections that require hospitalization or more serious management strategies. So next slide, please. So we are looking at the signs and symptoms of systemic infections and local infections. So on the left, you have localized UTI symptoms. On the right, you have systemic UTI symptoms, and you can see what they are. So localized UTI symptoms: dysuria, urinary urgency, urinary frequency, incontinence, urethral purulence, that's discharge from urethra, lower abdominal pain, cramps, or pressure. And then in the systemic UTI symptoms, we have fever or hypothermia, you can have recurrent chills, delirium or confusion, most likely seen in elderly people, hypertension, tachycardia, costovertebral and low tenderness, or flank pain. And flank pain, the two of them are not the same. So both local and systemic UTIs can have risk factors, and risk factors can affect clinical outcomes if not taken into consideration. So it's always very important to take risk factors into consideration for every disease, for every infection, for everything you're managing in the patient. And these risk factors can affect outcomes. For UTIs, they include age, anatomic or functional abnormalities of the urinary tract, the kidney stones, who are immunocompromised, people that have their catheters inserted, neurological patients, pregnant women, or UTIs. Also looking at people who have diabetes, if it's poorly controlled. Then antimicrobial resistance can also worsen the outcomes, especially if you use an antibiotic like local resistant patterns somehow. Next slide. So what the current guidelines say about diagnosis of UTIs? So diagnosis is important. Like I said, if you can't diagnose it, you can't treat it. You need to diagnose it properly to now know the right thing to use for it. So the EAU guidelines are really what we're going to use for this. Anywhere use another guideline or let you know that the EAU guidelines for 2025, that's the correct guideline we're using. The EAU guidelines recommend that for cystitis, you diagnose cystitis in women who have no other risk factors for systemic urinary tract infections based on the focused history of lower urinary tract symptoms. So, once these three symptoms are there, diagnose cystitis. There's dysuria, that's pain and urination, there's frequency, urinary frequency and urinary urgency. And then the absence of vaginal discharge. It is cystitis. Once a woman comes with three symptoms, you do not necessarily need to get the test done. You don't necessarily need to get the test done once these three telltale signs are. So it takes us back to the survey where I asked whether a test needs to be done before these patients can be treated. And 65% said yes, the test must be done. No, the test must not be done. Okay, you can start treating empirically once these three things are there. The guideline also goes forward to say that urine culture should be done in the following situations. If you're suspecting acute pyelonephritis, that there's another symptom, a systemic UTI symptom that is there, yes, then take a sample, a urine sample, and say, okay, we need to do something. Or the symptoms will not resolve, or they will occur within 4 weeks after completion of treatment, or women who present with atypical symptoms of pregnant women. These 4 cases are where the guidelines say, yes, urine culture should be done before treatment. Okay? You can take a sample and you can even start something empirically, and when the results come out, you change based on the results you've gotten from the diagnostic evaluation and laboratory investigation. So recurrent cystitis is very important because in the first case study, everybody said we have almost everybody said we have recurrent UTI or recurrent cystitis, right? So how you distinguish cystitis from recurrent cystitis is if the patient has at least 3 episodes of cystitis in a year, or 2 episodes of cystitis in the last 6 months. But for Zena, she just said she's only had it before and it was pregnancy. So she hasn't had 2 episodes in the last 6 months, per se, and 3 episodes in 1 year. Okay? So everybody runs to the current. Oh, it's recurrent. She's had 2. In 3 months, and she wasn't a patient, she just said she had something like this, right? Hello, can you hear me? Yes, ma'am, we can hear you. Who can hear me? Thank you very much. So recurrent cystitis is diagnosed by urine culture. Because you need to be sure if it's recurring, you need to understand why it is recurring.
Hello, Commander.
Hello, can you hear me?
Yes, I can.
Okay, can you hear me?
Yes, please.
Okay, fine. So, like I said, this needs to be distinguished. 2 episodes of cystitis in the last 6 months, and that was why everybody ran for recurrent cystitis, and that should be correct. And the one who didn't see, and the one who didn't see that was 3 months. That was 3 months. So when somebody comes with a recurrent UTI, you must get a test from urine culture, urine MCS must be done, so that you understand whether it was a treatment failure or atypical organisms. Because cystitis is mostly caused by E. coli, and but then of course we have other organisms which can cause UTIs. E. coli is about 80 to 90% of the time. So next slide. So urethritis, the guidelines say that you should diagnose urethritis based on the presence of any of the following. So a patient shows up and the patient has mucoid, purulent urethral discharge. You can say, oh, this is urethritis, right? You can get a test done, a gram staining of urethral discharge can be done, right? And then if a urine sample of this patient, properly collected urine sample of this patient, has a positive leukocyte esterase test in the first void urine, that's the first urine in the morning, any of these three parameters can be used to diagnose urethritis. Diagnostic of urethritis. You don't need to go for any which one that you can do. So for most of us in the community pharmacy setting, the first criteria is what we will most likely use. That's what we will most likely use. So for urethritis, let me say it now before we move forward. Urethritis, we have two types under the guidelines. We have non-gonococcal urethritis and we have the gonococcal urethritis. The gonococcal urethritis is caused by Neisseria gonorrhea, while the non-gonococcal urethritis can be caused by other organisms like Chlamydia trachomatis, Mycoplasma genitalium, and the rest. So most often than not, when urethritis shows up in the community pharmacy setting, it is advised that we treat as if it is both, because most times we are not able to distinguish, except the person goes to get some kind of tests done. And most times, we know how our patients are. Some of them don't know they know what it is. So, guidelines recommend that when you suspect or suspected urethritis, the gonococcal urethritis, you just use what can take care of the suspected organisms. We're going to see what the guidelines say in treatment. So for pyelonephritis, the guidelines say that pyelonephritis is suggested by fever, chills, flank pain, nausea, vomiting, or postural-vertebral angle tenderness. You can check up where the postural-vertebral angle is so that you understand. It's tender, it's painful, I don't know how to explain, it feels like a burning sensation around there when someone has pyelonephritis. So once the symptoms are present, it is suggestive of pyelonephritis. And then the guidelines say that urinalysis should be performed. The patient needs symptoms of pyelonephritis. Urine culture should also be performed. And then imaging can be performed to exclude urgent neurological disorders. Next slide. So we have something called asymptomatic bacteriuria. Asymptomatic bacteriuria, we have most all likely seen where a patient comes with a test result that says they have bacteria in the urine, but this patient has no symptoms. The patient has no symptoms of a urinary tract infection. The EAU guidelines say that you should not screen or treat bacteriuria in the following conditions: people who don't have any risk factors, people who have regulated diabetes mellitus, there's no need, postmenopausal women. Postmenopausal women, it's been found that most of them had some level of bacteria in their urine due to some changes due to menopause. Patients with recurrent urinary tract infections, if you see asymptomatic bacteria in them, do not treat. It's not even diagnosed. So asymptomatic bacteria is only treated in certain categories of patients, and we'll see that later in the slides. So we have bacterial prostatitis, not a urinary tract infection per se, but because of where the prostate is located, it causes urinary symptoms too. So when we talk about urinary tract infections, we add it in because patients will come with urinary symptoms, but it is prostatitis that they are having. So acute bacterial prostatitis usually presents abruptly, acutely. voiding symptoms, so the person finds it difficult to urinate, urine volume is low, the person feels like urinating, but it's not coming out. The urine stream is disrupted, it doesn't flow like normally, like men, it goes, there's dribbling too. And then it's also often associated with malaria and fever. Then the chronic bacterial prostatitis is defined by these symptoms, but it persists for long. That's what makes it chronic. So in the next slide, we'll be looking at what the guidelines say about the treatment of UTIs. So, but before that, we need to look at choosing wisely. Antibiotic selection for UTIs, we need to understand how to choose the best antibiotics for the treatment of UTIs. So, the choice of antimicrobial therapy should be these factors, but not limited to these factors. Like I said earlier, every factor, all 9 that I mentioned in the survey, they are all important. Very important to consider them: age, availability of the medication, because the guideline might say, oh, this is what is first line, but that medication is not available in the country. So you have to consider it. The medication history of the patient is to consider, because it's in medication history you find things like allergies, or if the person has a recurrent infection, we find out that, oh, this was resistant and didn't work, and the infection occurred because of relapse. Allergies, important, spectrum of activity, tolerability, and adverse reactions, the costs, very important. All these factors are very important. Adherence, we need to find out whether the dosage regimen is okay and easy for patients to adhere to. For some patients, depending on how their brains are, the kind of jobs they do, or whatever it is they do, we find out that some certain medications, their dosage doesn't work, and they will take the medication, and of course, they will get better. So, we have a few consequences because we're not I'm sure we know some of these consequences, but just reiterating.
I'm not surprised when she
if we choose the road back to
that is not what was supposed to be team.
We have persistent infections, recurrent infections. We can have severe and complicated infections that we're just going to do in 5 days, or because the wrong antibiotic was chosen, it lingers and complications can set in. We have increased risk of antimicrobial resistance. This is one of the challenges facing healthcare practitioners when we use antibiotics. There's a lot of resistance. I know some of you have come across some test results where you see that most antibiotics, they are resistant to bloodness, and you're wondering, what are we going to do for this patient? Everything becomes resistant. It's very important to know that this is a very huge consequence, and we should also make sure we educate and advise our patients to use the antibiotics the proper way.
I can hear you also.
Okay, you can hear me also.
I think, okay, we're back now. The audio is back. We had a technical glitch. Please go on. So it will be done in 10 minutes. Thank you.
Okay, fine. So it's fine. These consequences of wrong antibiotics, they might sound simple, but they're not simple. Imagine putting them all together and how they affect the lives of the patients and the health of the patient, and also us. One important consequence I'd like to mention is that when we choose wrong antibiotic for patients, we can lead to loss of confidence or trust in the healthcare practitioner. The patient is not getting well, they feel that this person doesn't know what they're doing, she doesn't know what she's doing, he doesn't know what she's doing. And they might not come back to you when they're the next time. But they can tell other people, these people, I heard that you gave me back, you did not work, you did not work. And I would like to say this to my colleagues. whenever you have a case that you know you cannot handle, please don't try to test the waters. If you know that it's beyond your scope of, beyond the scope of what you know, please refer. I would like to say that again. If it's beyond the scope of what you know, refer. It doesn't mean that you don't know anything. It means that you know enough to know that this is beyond you. Please refer. Next slide, please. So in the next slides, we are going to see what the current guidelines say about the treatment of UTIs. I've tried to put it in the table in a way that it can be easy to understand. So for cystitis, you have the first line education. It's not like I talked about the factors that affect choice of antibiotics. So this guideline gives us first line. Have you seen phosphomycin? Right. You've seen, please raise your hand. If it's here, it's not readily available. With methicillin, this was this correct. With methicillin is not available. I haven't seen it in so you use the methicillin, the local resistance pattern. So if nitrofuran, this that wonderful drug for it, but if local resistance is more than 100%, that's when you can use it. It's more than you can use it. So the fluoroquinolones are an alternative, but then you only use it for cystitis when it is considered inappropriate to use other antibacterial agents. For example, the patient is not responding to men. Cystitis in men is very, very rare. But if cystitis is going to show up, then most times they will have you have to spend next slide. Next slide. What the treatment of pyelonephritis. In the treatment of pyelonephritis, the empirical oral treatment that is recommended by EAU is fluoroquinolones. Okay, then ciprofloxacin. The resistance should be less than 10% if you have to use this. For all the other agents, the cotrimoxazole, ceftriaxone, ceftriaxone, you can only use them if you have given an initial IV dose. Long-acting recommended empirical oral treatment for pyelonephritis. For symptomatic bacteria, like I said, you don't treat. You only treat in particular patients with risk factors, such as related medicine. Or for patients like this, most of them will see a professional. So in the management of urethritis, like I mentioned earlier, with doxycycline or azithromycin if the patient is allergic to doxycycline. There are other alternatives where you have ceftriaxone, 100 milligrams orally plus azithromycin and all that. Levofloxacin and ofloxacin.
Just ask if you're giving him his phone.
For the treatment of chronic bacterial prostatitis as first line. Can you hear me?
If I want to collect it, how do I get it?
Hello? Amanda, are you there, ma?
Can you hear me?
Yes, I can hear you.
I will ask him to.
Is it breaking?
He's late for me. That's the
Hello? Okay. Then,
And they used to respond to this it's pharmacy.
Okay, Commander, please, can you hear us from Kano?
yeah. So now, ladies and gentlemen, so I need that next one. Yes. Okay. I think the network is there. Yes. As mine on screen. I have to
Okay. Okay, I can hear you now.
Can you hear me?
Can you
Okay,
hear
so
us?
ladies and gentlemen,
Yes,
I
I
can
can.
you hear me? So that's why I have to tell them they should listen to this last 5 minutes. Very important. So next slide, where we are right now.
Okay, Commander, just a moment. YP is in the house, please. She's just going to be concluding in 5 minutes. And she needs our attention. Please, I plead with you. Let's listen. The noise and the hall here is too much. Commander, can you hear me now?
I can hear you.
Okay, so we are all ears. Thank you.
So,
Slide that's irritating me.
dear colleagues, young pharmacists, I want us to ask ourselves a pertinent question at this point. Are all brands created equal? Are all brands the same thing? Because I know some of us, we've had these arguments amongst ourselves or even with our patients when they're looking for particular brands and we are telling them all of them are the same thing. Are all of them the same thing?
Yeah. No.
Theoretically, yes, all of them are supposed to be the same thing. All of us are supposed to be the same thing, right? Because they're supposed to contain the same active ingredients. But chemical equivalence is not the same as bioequivalence. So they can contain the same active ingredient, the same quantity, but they do not need in the same way. Research has shown that generic brands, they contain the same active ingredients. Yeah. Little brands. Things that make up a tablet or a capsule or whatever suspension. And the way a tablet formulate properties of that formulation, for example, disintegration, friability, dissolution. The time it takes for a tablet to disintegrate is very important in the overall therapy we want to achieve. It takes longer, the bioavailability will not be the same. So there's a research that was carried out in Lagos, Nigeria, assessing the physicochemical properties of 10 different brands of levofloxacin and their bioavailability. 10 different brands registered by NAFDAC in Nigeria. And this is just one of the results for the physicochemical properties. Now, because the physicochemical properties are different, the bioavailability is not the same. If you see the slides on the bioavailability, some of them are far off, some of them are
They're giving one.
as close to the little brand
This is
as
Sanofi.
possible. So the little brand disintegrates. Some innovative which has shown that chemical equivalence does not mean that they are bioequivalent. And one of the things I'd say personally is that multinational companies, one of the things I like about is that they have a research and development unit that is very active. What they keep doing is trying to find ways to make medications to work better, to work faster, do the job in better ways. Just the way technology is. The next couple of devices we will simplify them as much as possible. It's just the same way that some companies work. So it's very, very important. Brands are not, because it's not just the active ingredient that makes a medication. All the inactive ingredients, they have a role to play. Eventual bioavailability of that medication, and I want you to hear it at the back of your mind. It's very, very important. So maybe some guidelines on how to manage them. Look at the signs and symptoms again, have them at the back of our mind, and check. The download is easier, and we're able to find differential diagnosis is important. Differential diagnosis, I think we focused on it last year, where we were trying to make sure that the distinction between all the tract infections for important to employ antibiotics to achieve measure. We are complaining that antibiotics are no longer working. As custodian of medicines and we are pharmacists, it's very important that we live by example and do the right things to medications. Prescribe antibiotics only when necessary and use the appropriate dose and dosage. Very, very important. If we are seen doing the right thing, we need custodians of medicines. It's easier to get the healthcare professionals to do the right thing. Recommend antibiotics sparing approaches for the prevention and treatment of influenza as much as is possible. It's part of the antibiotics stewardship measures. Screen all patients that have urethritis for other STDs. Urethritis is mostly a sexually transmitted disease, mostly. So it's important that when your patients show up for that, we should get every other STI test, HIV, 1 and 2 hepatitis, VDRM, and all that. This also helps to establish you as somebody who's knowledgeable and knows what he or she is doing. All patients with urethritis should have their partners treat them, whether they have symptoms or not. They should get treatment immediately. All patients treating urethritis should avoid sexual relations as a 1 week after completion of therapy. If they really have to provide them some safety measures. And please make sure you follow up on the patients. That's what helps you know what works and what doesn't work. Some of them might not come back to tell you don't call them. It's very important to follow up on the patients. And lastly, I would want you to develop a checklist or SOP on how you manage it based on correct guidelines. It makes it easy. Just like a checklist. Or when somebody comes to this, I should do this, do this, do this, do this. Maybe like 6, 7 lists for urethritis, or pyelonephritis for this. What do I do? This, fair, depending on what it is. So their concerns that today that we've not heard before. I've said what we've heard before. All I've done today is just to refresh our minds and just have a little conversation. And like I said, what is most important is that you go back, do your own research, study, learn, and share with others.
My own is that when we were supposed to focus on collect something. Stress.
Share.
That's not good right.
So things will change. And thank you.
Please let's jam our hands together for fun. Okay, so one last thing before we leave. Thank you very much, Famada. Can we all log into menti.com? Smartphone, just go online to menti.com. For those of us at the